Right, so I'm going to have a few slides talking about diabetic macular edema. And again, this is the science disclosure as before. And we already know from the last talk that laser is still needed in most cases of diabetic macular edema. And the question is how we can improve the way that we do the laser. As you can see here that this is kind of a case that is quite common, that you got exudation, and then when you see on the angiogram, you see the leakage, and you see the microaneurysm, and then you can see the leakage. So it's something simple that you see. Now that you can see an OCT have a similar kind of changes. And so we've been doing this for a while, and then we cover the area, and then a few months after the laser, then the exudate starting to improve. And then again, our general policy is that if they start improving, we don't need to do anything more. We can just leave them. And then again, as time goes along, that they can improve further without any further treatment. So single treatment, if they start to improve, that you don't need to do anything more. And you would not really see that there is any meaningful scarring as such. And we have published this back in 2009 as the pre and post laser changes. And again, some of you heard of the concept of transfoveal treatment. And again, one of my American colleagues, not the one who sat in the panel today, but also from California, often talk about this kind of laser but deliberately hit the fovea. And so that quite often the question is, well, should we hit the fovea? And if not, how close can you go? So this is just a case to illustrate that, how close can we go, but there is often a caution that I certainly wouldn't think that you should do this kind of treatment when you have only just starting out doing Micropulse. But for experienced Micropulse surgeon that the setting is correct, the way that you do is correct, then we're getting very close to the situation. As you can see here that you got a localized edema, you got the microaneurysm quite close to the fovea, and then if you actually magnify it, and you can see that it's really very close to the fovea. And I would argue that no one in the right mind would actually laser this patient. Well, when I say laser, I mean conventional laser. So obviously, we feel that it's very comfortable to getting extremely close to the fovea. And so this is the patient that we treated one treatment, and then we had the Micropulse laser, and then you can see that would able to improve the situation. And this is before and after the laser. As you can see, there's no specifically scarring associated with it. So the concept of whether you need to hit the fovea or not and how close we will go, to us is quite often that we don't deliberately hit the fovea, but we're getting so close. And what Jeff talking about transmacular or transfoveal laser to what we are talking about not getting to the 100 micron from the foveal center, I'm really talking about maybe just one spot different. So I don't do that last spot to deliberately hit the fovea, and then Jeff seems to feel that it's more sensational that the technology is so safe and hit the fovea as well. So I don't think we are bigly disagree with each other. And the only thing is I don't deliberately hit it, just purely feel that I can live with one spot less as such. So the kind of things then, the little bit more practical side. And again, what we tend to do is to look at how we treat the area and how to really do that. And in general now that, like what Tricia have mentioned earlier, that we are now tend to be using lower energy but covering a larger area. And certainly we're covering all the area that the edema is present. And indeed that sometimes that we go slightly beyond that because sometimes that you can't be 100% sure where the edema is while you're lasering. And even if you got OCT on your projection screen, sometimes that you do want to treat it slightly beyond that, and it seems to be a reasonable thing to do when we don't see any scarring as such. We tend to follow up the patient after 3 months, and in particular those patients with got large area of edema, and sometimes it take a bit longer to improve. And if you've got large area edema, we would quite often that we do retreat some of the persistent area. And we're using the same protocol OCT guided. Usually for us in England, we haven't got that much time to see patients. So if you've got a small area of edema that you're quite comfortable that you're probably not going to treat in 3 months' time, because even if you like the last case I showed you, the first case I showed you, that once you think that you're going to work, and then we can just leave them. So in small area, we tend to see them 6 months later. So it depends on your healthcare system and what you prefer. So as I already mentioned, that can we treat the fovea? Well, if you wanted to, and then I would just leave not to. How many times can you retreat? And again, we have been certainly retreated more than 3 times. And again, we do get anti-VEGF. So if they really don't responding, and then we would carry out with anti-VEGF treatment. And I know that in some country that anti-VEGF reimbursement is not possible. So some of our colleagues have repeated treatment more, and actually that's something that we're still looking into. So our general consensus, the pragmatic approach is if you don't see any scarring, then you can probably keep going. And then I think that seems to be a reasonable thing to do. And again, obviously that if you have access to anti-VEGF, then sometimes that you might want to do that. So the question is, well, is it better than anti-VEGF? I wouldn't claim that it's better than anti-VEGF, only other than that, if it does work, it lasts longer and it's a bit cheaper. And anti-VEGF work very fast. And again, repeatedly, we have said that, laser work much slower. But, unless your patient is going to die next month, then you probably don't need to be worried about that, whether they take 3 or 4 months to improve the vision or not. But again, that is something that individual patient at individual basis. We still think that the combination is a good option, and certainly there is some coming up more and more evidence that laser, in particular with Micropulse laser, you can reducing the frequency of injection. That is still a controversial. We haven't got a really proper study to confirm that, and there's anecdotal experience to suggest that. The difficulty is laser company could not afford to pay for all the injection, and the injection company doesn't want to anyone to know that laser would actually reducing the frequency of injection. So we just need to wait for someone who are diabetic and very rich that actually can fund some of the study. And no government agency are particular interest in either, because it's too technology, they would say the company should fund it. So again, we've been trying to get that funded, and so far no one really want to do that. For new Micropulse user, I think that, as Sasha mentioned earlier, most surgeons undertreat, and I think it's important to know that if you think about it, that if you got about using our guidance of 160 micron, and then if you're doing 100 spot, that will cover 1 disc area. So you can actually look at the OCT scan and look at how many disc area of edema there is. And then once you finish inverted comma of your Micropulse laser, you expect that you have 2 disc area. You're supposed to have 2,000 burn, but then you have 200 burn, 200 burn, and then you only done 50, then you're probably undertreating. So I think that is something to think about. You also need to pick your cases. And again, there is some experience that even for those who have failed previous laser seems to work, but they are not good cases. And you do need to have surviving RPE cell and for it to work. So do consider that importantly, that some other reason that the patient that they don't respond, and because that all the RPE cells are already scarred and damaged. And again, when you got lots of edema, it might be reasonable to reducing the edema first with anti-VEGF. Learn to titrate the power is still a little bit of a challenge. And again, there is some debate whether we should titrate the power. And again, there's some controversy over it. Some Micropulse specialists are now advocating just a standard power, but lower than normally required, but do a lot more spot. And again, we still think that titrating power give the patient more individualization. And again, that would be something that we need to learn how to titrate the power. And don't be too worried that in the very beginning, you're doing Micropulse, you see a little bit of scarring, right? And obviously that if you see a little bit of scarring but working, means that you're slightly too much power. Auditing your result is a part of the medical practice. So ideally, what you would want to do is work and you don't scar. And we can have now tell you that once you work and not scarring, gradually, then you can go and hit the fovea if you so choose to do so. Thank you very much for your attention.